Thank you, Mukesh, and good morning, dear friends. It's nice to see an almost packed hall on a lacrimal session in the morning. Now, when a patient comes in with congenital dacryocystitis, the usual answer to the question whether it's a serious condition is no, it's a minor condition, it will go away, which is true most of the time. But once in a while, you will get a child like this, which we reported in the ophthalmic plastic reconstructive surgery a few years ago, a neonate who developed a huge orbital abscess within a few days of birth due to acute dacryocystitis and who needed an abscess drainage. In other words, in the occasional patient with congenital nasolacrimal duct block, things are not all that simple. Now, when we look at watering in children, this is very frequent in clinical practice, not only for us ophthalmologists, but also for pediatricians. And parents are very, very concerned, almost to the point of tearing themselves. There are many causes, of which congenital nasolacrimal duct block is the commonest, but rare conditions like congenital glaucoma must be ruled out with an adequate clinical examination, and for which we need to be very careful. We need to rule out serious conditions like glaucoma, corneal pathology, foreign body, etc. as appropriate. And whenever everything suggests that it's congenital nasolacrimal duct block, it is congenital NLDO, it's fine. But if there's something amiss, it's always a good idea to have a sedation or examination and anesthesia and have an open mind and be willing to change the diagnosis if possible. Now, congenital NLDO is something which responds well to conservative treatment, and acute dacryocystitis is uncommon, but these children need systemic antibiotics. Now, this is one important result that came out of that case report that we sent in and which was published. If a child has acute dacryocystitis and the mother has been advised massage, I think it's important to tell the mother not to massage when there is erythema or swelling in that area. I think that's one thing that comes out, because the child has acute dacryocystitis in that setting, and if you are massaging, what you're going to do is to send in an infected embolus through the valvulus veins in the system and potentially produce spreading infection. So that is one little thing that I think you could add to the advice that you routinely give for massaging in a child with CNLDO. Now, what is the relevant anatomy? This is the diagram that all of us practice as postgraduates and we are thorough with. This part is very simple, very straightforward, but it is only half the story, because when you look at the other end, the passage has an upper end and a lower end. Ophthalmologists only used to look at the upper end and feel very happy about it. But why we never used to understand why some probings succeed and why some don't is because we never looked at this end of the passage. And there are cadaveric studies which show huge number of variations in the way the nasolacrimal duct opens into the inferior meatus, which could be duplicated, which could have operculum, and many, many variations, which is why a blind procedure like a probing, where you just go in, push, feel for the opening and come out, is only half the story. And we'll come to why recent developments have improved our successes in this procedure. When you look at clinical features, the anatomical block done in cadaveric studies, especially in stillborn bodies, show almost 50% anatomical blockage, but clinically 1 in 20 children or so, more so in premature children. Symptoms everybody is familiar with. There is regurgitation on pressure over lacrimal sac when you look at the signs, and upper respiratory infections tend to worsen the symptoms, particularly in partial blocks. In partial block, what really happens is that there is some amount of drainage happening and the child develops an upper respiratory tract infection. So, two questions that I asked the mothers with a congenital NLD block are: A, are there any symptom-free intervals? If there are symptom-free intervals, it's a partial block and the child may not need probing. If it also worsens significantly during a URI, that's also possibly as suggestive of a partial block. Antibiotics need to be given topically, especially when the infection is worse. Local hygiene needs to be maintained, and treatment of treatment of cuffs and goals, particularly in cases with partial nasolacrimal duct block. Now, the question is, how do you advise lacrimal sac massage? There are as many ways of doing lacrimal sac massage as there are ophthalmologists and pediatricians particularly. So what is important is to tell the mother or the caregiver, primary caregiver, to feel for the medial canthus, which is a prominent structure which can be palpated, and to give a hydrostatic massage. So essentially the aim is to give a hydrostatic massage which milks the fluid down into the nasolacrimal duct and will open up the soft tissue block. So obviously there are some people would give no directions, just massage in that area. Some people would give circular motions. But what is more scientifically justifiable is to ask them to milk it down and explain to the mother why you're going to be asking her to do that. There are some controversies in the procedure of probing and syringing. So now suppose the child is very young and comes to you with a congenital nasolacrimal duct block. Most of the time we are asking them to do trial of sac massage or conservative treatment. If it doesn't improve for a few months or till the child is about 1 year of age, in my clinical practice, that is the time when I start considering probing, except children who have episode of acute dacryocystitis. Each acute dacryocystitis episode is actually an emergency where the child has to be rushed to the hospital, has to be given oral antibiotics, there is a risk of infection spreading. So if the child has acute dacryocystitis, there is a scope for early probing, but otherwise normally we conservatively wait till about 1 year of age on conservative treatment, especially with the massage being explained very well. But when we decide on probing, there may be controversies, people may differ. I'm sure there are a lot of differences of opinion here also, but basically follow a logical approach in the sense that if the conservative management is not improving, because we know that conservative management treats or cures 90% of these children by 1 year of age. So we are really right in waiting for some time. GA is essential, using a cuffed endotracheal tube. I do not do mummification, which is of course been described for doing probing in very young children by wrapping the fellow up and pushing in the probe. But essentially what you're doing is, in my opinion, the probing without general anesthesia is a painful procedure unless you're giving the blocks, and topical anesthesia really doesn't help, so we must not possibly be doing mummification, at least in my opinion. Now, in terms of the procedure itself, it's simple, everybody has been doing it. We should prefer the upper punctum, which is basically more straighter, and also in case of any inadvertent aortic injury, the lower punctum and the lower canalic system being a little bit more important, you may be justified in doing it to the upper punctum. You go in backwards, downwards, and laterally in the direction that the nasolacrimal duct passes, and different probe sizes are available, but suffice it to say that we must choose an optimum probe size. The numbers given are usually irrelevant. Most of them local manufacturers, really doesn't correlate as to what size at what age, but it should not be too fine. If it's too fine, what you do is you may end up making false passages, which Mukesh spoke about. Or if it's too thick, then again possibly you're kinking and you're not going in easily. You also must feel, because it's a blind procedure, a sensation of give as you open up the soft block, and after that you need to do a little bit of reaming. I'll spend a moment on that, because as you go in with the probe, what you're doing is just perforating. If it's, let's say, a membrane, you perforate it and then you come out. That's not enough. After you perforate, you need to actually go around using the bone as a fulcrum to ream it. So in these cases we find a very high success rate of probing. Actually, we'll come to that in a couple of moments. If you ream it adequately, then I think it does as well as a balloon dacryplasty, which we'll touch upon a little later. So reaming is very important in enlarging the perforation that you have made into the soft tissue. You can confirm by many techniques, but the best technique possibly today is nasal endoscopy. We'll come to that. And otherwise, syringing is a well-established technique of finding out, or a blind procedure of metal on metal contact, which is very rarely used. Now, the concept of the bony block, quote unquote bony block itself is in doubt, because most of the time we know that what we feel as the bony block is nothing but the probe hitting against an enlarged turbinate. So what we used to think as postgraduates or even later, that the bony block means there is no opening at all, there is no canal. That really almost never happens except in severe malformations, etc. So in most cases it is actually a huge turbinate which you can address separately and make your probing successful. Now today I think the biggest development that has happened in the area of treatment of NLDO is the role of nasal endoscopic examination. What you see is what you get. So if you see what is happening to your probe, where it is coming, you are able to make the procedure much more successful. And in selected cases, especially in recurrent or failed probing, the procedure of inferior turbinate infracture, where we infracture the turbinate, improves our success. and in some cases silastic intubation, but one needs to be careful that intubating the closed system is not as easy as doing it in an open DCR. Now, what is the changing realities of congenital NLDO? There's greater understanding, there's better instrumentation, there's also a changing perception that we really do not want to push any patient, particularly a child, into a open surgical procedure. So all these have opened up a lot of newer options. That is, probing and syringing is being tried in older children. Because of the increased success, older children also primarily, even a 7-year-old, 8-year-old, 10-year-old who comes to me for the first time, goes through a trial of probing plus nasal endoscopy plus something else that you may need, like an inferior turbinate turbinectomy, inferior turbinectomy, or inferior turbinate in fracture. Also, you have the option of balloon dacryocystitis, which we may cover in a short while, with its own limitations. So today a probing procedure looks like this, that you have to have a nasal endoscopy ideally to be able to visualize and take care of anything else in the nose which will come in the way of a successful probing. So this is of course a balloon dacryocystitis. I think if time permits, we'll see the video. Now this is actually a video which I thought would be useful. Balloon dacryocystitis, unfortunately, I must say, I was one of the first to do and to speak about it in many fora, but it's a procedure which has come and possibly also gone, because we could not indigenize it. The cost per unit was far too high to be able to justify it, and the results of a good probing and syringing, in my opinion, done with adequate amount of reaming, with nasal endoscopic visualization, and doing any associated procedures like in fracture or intubation, the success rates actually match a balloon dacryocystitis. So expense on one side, the fact that you can do something else and reach that level and avoid open surgery. So this is, for example, so this is just okay, we'll use it as just a picture wherein the inferior turbinate has been removed to produce, to see the probe and the catheter in place. So this is a view without the inferior turbinectomy, because the child had a massive inferior turbinate which had to be removed, and this child did not need an external DCR. In other words, today we are able to avoid an external DCR in most cases. So in my hands, for example, pediatric DCR is extremely rare procedure. So not more than 1 in 25 to 1 in 100 of adult DCRs needs a pediatric DCR. Because most of these children, even at older age, we can get away without an external DCR. Given a choice, none of us would like to go in for open surgery. So that's the case with all the patients who come in with congenital nasolacrimal duct block. So with the use of nasal endoscope, with a better understanding about nasal pathology and also instrumentation, we are able to avoid an external DCR in most of our patients with congenital nasolacrimal duct block. Thank you very much.